good evening, viewers. How are you doing this evening? Welcome to your favorite medical show, Ask Dr. Saw. This evening, we're coming to you live from TBN Studios, as we always do. Last Tuesday, there was some important things with the critic himself. So the show was aired a little bit later. But rest assured, you will see the show is going to be on every Tuesday evening at 8, and if you don't see it at 8, it will be shown later on. So thank you for joining us. We hope that you're all in good health and having the best of many worlds. So this evening, as usual, the reason why the show is what it is and why it's named what it's named is because of Dr. Saw. Good evening, Dr. Saw, and thank you so much.
Hi, Akash. Good evening to you and the viewers. And yes, thanks again for having me.
Yeah, and Dr. Saw, I just want to say this, that on behalf of the viewers here and some of the feedback I've been getting out there is that they really appreciate what you're doing, and they really appreciate the wealth of knowledge that you bring to this platform, and to break it down the way you do for everyone to understand. So thank you again for that too.
You're welcome. I'm trying my best. Hopefully, we're making inroads. So yeah, I'm happy that, the feedback is positive.
Brilliant. So this evening, viewers, we are talking about epilepsy, and we just got about 2 questions from last week. So we'll be dealing with those 2 questions later on, just before the end of the show. But this evening, we are talking about epilepsy, or what seizures in Guyana here, Dr. Saw. I always like to share my little experience with you when I hear about certain things. I mean, if I knew what it was then, because back in the days, you would hear people catch fits, right? And
Yes.
and then it was stigmatized. Sadly, it was stigmatized because we stigmatize people. Don't worry, that the man has catch fits. It's such a joke.
Yeah.
But what I do know is that seizures have something to do with the brain. So I'm going to ask you this evening, Dr. Saw, what is epilepsy? And is it the same as a seizure? Is it the same thing we refer to as catching a fit?
All right. So they are not the same thing, but one can be okay, let me just break it down. Definition of epilepsy. So epilepsy is a tendency for having seizures, unprovoked seizures. So the tendency for recurrent, unprovoked seizure is called epilepsy. So seizure itself is something, can be as a result of other causes, but a type of seizure is categorized as epilepsy. So let us repeat that. So you have seizures, and there are different types of seizures. But one category of seizure is defined as epilepsy. And it is, so when you have epilepsy, you can have seizure one time, and that is not epilepsy. Whereas epilepsy is a tendency for having recurrent, unprovoked seizures. So that's your definition. And seizures, what are seizures? Seizures are dysfunction of the brain as a result of electrical malfunction of the electrical activity in the brain, and it can manifest in different ways. That is motor symptoms, sensory symptoms, autonomic symptoms, behavioral symptoms, and consciousness. So I will explain. I mean, there's a little bit detailed, so I need to break it down. So seizure is a result of electrical disturbance of the brain, and so you have a disturbance of the brain, and you can manifest as motor. So motor is about movement.
Right. So
you have a motor disturbance. You can have a sensory disturbance. So you smelling things, you tasting things. So that's sensory disturbance. You may have a behavioral disturbance. You may behave in an abnormal way. Or you may have altered consciousness.
Right.
And all of that, all of that can manifest as seizure. So when you and I talk about seizures, or when in the old days, as you say, in Guyana, when somebody say they're in fits, we are accustomed to know, or we tend to associate it with only that jerk and movement of your whole body.
Right.
That is what you would define. So that's a motor type of seizure. So we call it grand mal or generalized seizure, um, clonic seizure. So you're shaking and
Mhm.
you are in, spasm like, and you're shaking. That is one type of seizure. But you can have seizures in other ways, sensory, as I described, behavior, and all of that. But we'll come to those details in a minute. So that's your definition, really. And I know it's a little bit. So, did you get that point clear?
Yeah, 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 yeah,
Whereby,
yeah,
or
yeah,
to the
yeah, yeah, yeah,
viewers,
yeah, yeah,
whereby
yeah.
um, epilepsy manifests as seizures.
That's
Not
right.
all seizures are
All right.
known to be epileptic seizures.
Right,
So
right.
let me explain, just also say something on that, just to get it a bit clearer. So when you have unprovoked recurrent seizure, we can say that is epilepsy. So the definition is you have to have two or more seizures, right? So it's
Mhm.
unprovoked, it's not caused by something that you can, pinpoint at that point in time, and it's recurrent. However, for instance, if your blood sugar is low, you can have seizure. That is not epilepsy. That is a cause, and that is provoked by low blood sugar. Secondly, if you bang your head, you have a head injury. People bang their head, they get seizure. That is not epilepsy. That's a provoked seizure, and that's a one-off seizure. If that, however, that injury is recurrent and unprovoked because you have damaged part of your brain, then that can be considered as epilepsy. If you have a tumor of the brain, so you have a tumor of the brain or a bleeding in the brain, you can have a seizure. And that sometimes is the first sign. I've had a patient who, the wife called me up one day and said, Doc, the husband had a seizure this morning and they had to call the ambulance. Took him into hospital. The brain is damaged and function abnormally. Then we can say, yes, he developed epilepsy after the tumor or after the surgery or after the stroke or after a head injury or after an infection. So you can get you can have seizure due to meningitis, due to head injury, due to trauma of the brain. You can have a seizure as a result of that, but they're not classified as epilepsy until it becomes recurrent and unprovoked. So I think that shed light on it.
Well, it brings me to this other question, and I mean, you spoke just now about this guy was having seizures, and he gone to the hospital, he did a scan, found out that there was a tumor. What are other causes of seizures? Because how we all should be treated with seriousness. But what are some of the other causes?
Absolutely. So yeah, there are lots of causes, but when we look at causes of seizure is different from causes of epilepsy. So
Right.
causes of seizure, epilepsy is one of the causes of seizure, right? So you classify that type of seizure as epileptic seizures.
Right.
And when we say what causes epilepsy or that particular type of recurrent unprovoked seizure, it's difficult. 60% of the causes of those recurrent seizure, we don't know. So
Okay.
it's unknown for about 60% of patients. And it's usually multifactorial. They blame it on, all sort of environmental, genetic, and God knows what, because it is diagnosed as idiopathic or unknown. And then you have causes like structural abnormality of the brain. So if you have the brain hasn't developed properly, and you have the brain, you can have a seizure as a result of a structure. You have an infection and it causes some structural abnormality, or you have trauma to the brain and a damaged part of the brain. Those are structural abnormality of the brain. And then you have causes whereby there is a metabolic cause. So there are some metabolic cause where your calcium is abnormal, some enzymes to do with regulation of the brain chemical, they're abnormal. You can have that. A certain type of drugs and poisoning can give rise to seizure. They're metabolic causes. And importantly, there are genetic causes where there are some syndromes like genetic condition where those syndromes are manifested with seizure, among other things. So you can have developmental delay with seizure. You may have other genetic predisposition. Let's say you have a disposition for cancer formation and that. So there are some syndromes that are associated with developmental delay, seizure, and other neurodevelopmental problems. So you have genetic, you have metabolic or structural, and you have unknown. So those are the kind of theory behind why do we have recurrent seizures? Why do we have epilepsy? But that is why do we have epilepsy. Then you have seizure from other causes. So this is not epilepsy seizure now. This is your one-off seizure. Brain tumor, infection, your blood sugar is low, head injury, a low calcium, for instance, lead poisoning, drug withdrawal or overuse of drug, cocaine. You can take cocaine and you have a seizure. Amphetamines. We know clubbing drugs, that you use those amphetamine drugs, they can give rise to the seizures. Some sudden withdrawal of drug, sudden withdrawal of alcohol. You get alcohol seizures. Now, so those are other causes of seizures, but they are not epilepsy per se.
All right. So then I have to ask this: Are there any other manifestations of anything other than seizures to
Yes.
say these are other symptoms? There are other symptoms to epilepsy.
So when we describe, so if I describe seizure, then you would understand how it can manifest, and it is not only the tonic-clonic or the generalized seizure. So as most of us know, seizures, your whole body jerk, and you contract and you lose awareness. And so seizure is divided into partial and generalized. So you have partial seizure, generalized. So what I described there is called generalized seizure, generalized tonic-clonic or grand mal seizure. Then you have a type of seizure, it's still generalized, it's called petit mal seizure. So petit mal seizure or absent seizure. So and children, this is more common in children. So I may be talking to you and you just, for a couple of seconds, you gone blank. Mm-hmm. And then you continue, you can't remember what happened. You did not have any recollection that you were blank for a few minutes.
Right.
But I noticed that you were blank. Now that's absent seizure. Mm-hmm. So that can be a manifestation. So you don't have to jerk your body to manifest that. Mm-hmm. You can have, so when you look at the other manifestation, so seizure can be divided in, let me just give you the different types as well. So you have that generalized seizure, tonic-clonic. You can have atonic where your body collapsed, your muscles then paralyze and you collapse. Atonic. You have myoclonic jerks. These are generalized seizure where, sometimes your body jerk. Involuntarily, you have jerky movements of the body. Right, so you can have those jerks. They are like the muscle jerk, right? That is myoclonic jerks. So those are a type of generalized seizure. Then you have partial seizure, where one side of the brain is affected, one hemisphere. So in generalized seizure, they say it is both sides of the brain affected, whereas in partial seizure, one side of the brain affected. And there's a particular type like temporal epilepsy. Mm-hmm. So that part of the brain is responsible for communication and language. So you can manifest with communication problem. We have verbal dysarthria. Words are not coming out. You cannot form your words properly. So that can be a seizure. That can be a type of seizure. You may have some dystonic features where you're twisting your head on one side, your eyes are going in one direction. That's a type of seizure. You can have where your hand movements. There's a type of seizure where it starts from the fingers and it moves up the body, one side of the body. And that can be a type of seizure. Wow. You can have aura, like a sensation before the seizure. So you have aura, you can have certain smell, you're smelling something different. That can be a seizure. You're tasting something in your mouth when there is nothing that you have tasted. Abnormal taste in your mouth. That can be a manifestation. So these are sensory manifestation. You may have certain visual lines in your field of vision. and that can be a manifestation. You may have behavioral issues. You may be agitated. You may be losing focus. You're rambling. You're not making sense. You're pacing. So your behavior has changed, a bit aggressive, temperamental. Now that can be a type of seizure. So focal seizure, where one part of the brain affected, can be manifested like that. So when we describe seizure, it is not only that generalized seizure that we know of. There's so many manifestations. Behavioral, I said, sensory, motor, consciousness. And in partial seizure, it can also have one where you're aware and one where you are less aware. So, these are the different types. And in the seizure presentation, you have that aura where you have signals before. So even a couple of days before, a patient's behavior can change before they actually have the seizure. And then they have the seizure, and then you have a post-ictal phase, we call it, where you get drowsy, you may feel fatigued, exhausted, tired, which can last for a couple of days. So that's your manifestation.
Wow, here, Doc, you telling me all those things that I counted in my head is how many different types of seizure I go through on a daily basis. I kid you not. Here, you might think I listen to this. You telling me all these things. You telling me and asking me, I say, wait, here, wow.
I know.
All of that.
That is why when that question was asked last week and they say, what about epilepsy? And I said to you, I'll have to spend a day talking about epilepsy, because if I go into detail of each one, they have classification, they have different treatment and different ways a drug to use. From partial seizure, there's a different type of drugs. For generalized seizure, different type of drug. And it's all complicated, and that's why it's a complex, big area. But I just want to break it down in simple terms. And why epilepsy is important, we know that epileptic patients, they have a higher mortality. They die earlier. Death in young people are attributed to epilepsy. A big cause of death is epileptic death in young patients. They die suddenly. And there are various reasons. They say, some people say they have the drugs that they use have a tendency for heart arrhythmias and abnormality of the heart and all of that. We know that patients who are epileptic, their children have a higher chance of being epileptic. And also women who are epileptic, they're on medication, they have a higher risk of having babies that have malformations. So certain drugs, you got to be careful. They have an increased risk of malformation in babies. So it's a very important subject that we don't trivialize and say, fine, you're epileptic, take this medication. You have to look at a holistic way to manage these patients.
I have a friend whose mother was epileptic, and she died by drowning, because she used to go to the back to clean up, to wash the clothes, and this lady fell in this black water trench at the back, and she drowned. I know another kid who drowned also in a pothole on the road.
Correct. No, that is an important thing. And in one of the advice, when you look at advice for epileptic and how do we manage them, we tell them do not swim alone. That is one of the general advice. You should not swim alone. Yeah. Secondly, do not bathe a baby alone. So mothers who are epileptic, or even if you're a father and you're epileptic and you're going to take this child, you're going to give this baby a bath in a bathtub.
Yes.
If you get seizure, the baby drowned.
Yes. Wow.
So those are two important things, and sometimes we don't pay attention to that, and we haven't got that guidance. But those are important things that we should tell patients.
Should seizures be investigated, and how? How should it be investigated?
Well, yes. There are some seizures that are clear cut. Like for instance, something called febrile seizures. Young babies can have a type of seizures when they have fever. Young children, usually that's a type of seizure. And if it is a straightforward febrile...
They say it gets fever fits. They say baby get fever fits.
That's correct. So usually you get between, let's say, 6 months of age to about 5 years of age. All right, that's the age group. You usually get it. It's a multifactorial cause. So it's not the same as epilepsy. It's different. So that's a different type, febrile convulsion in babies. Now, that seizure, we don't need to investigate unless there are some red flags, which I will talk about if we have time, on febrile convulsions. But I'll come back to that. But yes, epilepsy should be investigated. And the reason is, one, it has implications. So if it has implications for your job. It has implications for if you're a driver, for instance, you should not drive if you have epilepsy and it's not controlled. I mean, even in the UK, we have guidance on driving. You have to be seizure free for 5 years to drive.
Yeah,
So, and
makes sense.
it's yes, indeed. If you get a seizure on the wheel, it's serious. So it has implications for certain jobs. So you want the diagnosis right. So I would investigate all epilepsy, all seizure, except for the common febrile convulsions, probably as a one-off. You don't necessarily want to identify the cause. So seizure, how do we investigate it? You want to do some basic blood tests, as I said to you, certain blood workup. If your sugar is low, if your calcium is low, if you have electrolyte abnormality, disturbance in the chemical of the blood, you can have a seizure from that. So you want to know, and also infection. So you want to know if this is a type of a cause, a known identifiable cause.
Right.
But the type of epilepsy that we are looking, where we said there's no identifiable cause, all these things are normal, and the only way we can make the diagnosis is you do like an electrical tracing of the brain. So they connect something to your brain, and it's called an EEG. Like how you do electrical tracing of the heart.
Yeah,
the heart one is called EKG or ECG.
That's right, yes.
Americans say EKG, we say ECG.
Yeah.
In the brain, you have EEG.
Okay.
Right. So that is a tracing to see the electrical activity of the brain. As I said to you earlier, you have electrical malfunction in the brain. So in the brain, you have neurons that excites and neuron that inhibits. So in those excitatory neurons and inhibitory neurons, they imbalance and they firing electrical activity, and that's how you get a seizure. So you see it in the tracing of the brain, and there are certain patterns related to different types of seizures. So the EEG. And there are other tests you can do, of course. As I say, there are causes where you have structural abnormality of the brain. So if the brain has got a structural defect, my brain is shrunken, my brain has got underdeveloped, you may do a CT scan or an MRI, usually an MRI, and you will see defects in the brain. What else? You can do a lumbar puncture. So let's say you have a patient coming with seizure and you don't know exactly what's the cause. You can do a lumbar puncture where you put a needle in the spine and you take some fluid out and you analyze it. MRI is also important to look at other causes. If you have a brain tumor, if you have a bleeding, you can see all those changes in the brain. Hydrocephalus, there's some, like the cavities in the brain are, disproportionately large or whatever, or too much fluid in the brain. All of that can give rise to seizure. And of course, MRI will give us those features.
Yeah.
So yeah, those are your.
Yeah, sorry to look a little distracted. I was just trying to get the message back on my phone.
Sorry.
That I wrote.
Oh,
here.
Okay. How are we doing for time?
So we got about 15 minutes to go. I'll say about 14 minutes more, to go. So we got a little bit of time here. How should we manage?
No, but I program it for 45 minutes, so we got to finish in 30 minutes.
No, we have the time. I'm looking at it. Yes.
Yeah. Okay, cool.
Yeah. How should we manage seizures, especially when someone is fitting? Should we put a spoon in their mouth like we are? That's the first thing when you're small here. So you gotta put a spoon in your mouth. Once you catch it fits, you gotta get a spoon and put this in the mouth. For what reason we never? I never knew. But what do we do?
No, so that is not encouraged, and that can cause more injury. And people say you swallow your tongue. You cannot swallow your tongue. How can you swallow your tongue? You can't.
Right.
So the thing is, yes, no, we don't do that. So the important thing, so the management of seizure, I'll come to that. But what you are talking about there is a management in a patient who's having a fit at that point. So we call the status epilepticus. Status epilepticus, you're fitting now. So I'm attending to you, you're fitting now. And then I'll talk about management of seizure generally, epilepsy generally. So your status epilepticus patient who are having seizure now, first of all, you want to ensure that they're in a safe environment. So if somebody gets seizure in the middle of the road, You don't want to take them out in a corner where they're safe. You are safe and the patient is safe. So you move the patient to a safe environment. If they're in a safe environment, you don't need to move them. There's no need to move
Okay.
them. You want to protect their body, protect their head or their body. So if they're in a space where they're jerking and hitting themselves, you want to cushion that in some way. Do not restrain them. So if you are shaking like that, there's no point me stop you from shaking. Because if I hold you down to stop you from shaking, I can injure you because you have lots of resistance. Your muscles are contracting and pushing me, and you can injure your ligament. So you don't need to do that. You just want to ensure that they are in a safe place. You want to cushion their head because head injury is very important. So you can put a pillow under their head. You can put anything to cushion injury so they don't hit themselves and injure themselves. You want to take away any restrictive garment. So if they have a tie that can choke them, take away their tie. If they have a scarf on that can choke them, you take that away. If they have clothing that is restrictive, tight clothing, you can undo the buttons. So you want to loosen their clothing. What else? And then, of course, most seizures would abort itself on its own. And then once they're finished, they may go into a drowsy state. You want to put them into what we call the recovery position where you lie them on the side. So you lie them on the side and you ensure that they're breathing. So,
Well,
of course, if this is a patient that is known to be epileptic, then maybe, somebody passerby or family might be wrong. If you're not sure as to the nature of that epilepsy, then, of course, you call the ambulance because it may be the first seizure as a manifestation of something serious. The patient may have a tumor, a stroke, a bleed in the brain, and they manifest as that. So, so
which
those
which
are the
which
things.
which brings me to something I was thinking of as what when you're talking about that, you talk about breathing. I'm thinking then, wouldn't this spoon that people usually tend to put, wouldn't that be so dangerous it can kill somebody, then it can actually block that
Block your
infinite,
airway. Of
yeah.
course, it can block your airway because one of the important things is that you have to make sure the
My
patient is
goodness.
breathing. And so it is not a safe practice. So we don't
I mean,
encourage it.
I've never thought about it, but now that you're talking about it, I'm always thinking that yes, I've always heard that is because
Mhm.
people would swallow their tongue or something like that. So you got to put the spoon for block them, not knowing that we can actually be causing. Oh my goodness!
Yeah. Yeah.
Wow.
So yeah. And then in some cases, so if a patient is recurrent, so family members, if you have family members who are epileptic, so patients who have most times we try to control seizure, and there are enough medication we can control seizure with. But in some seizures that are resistant sometimes, there are drugs we can give then. So let's say if I were to attend now, if I, as a medical personnel, you're attending to somebody in status epilepticus, whereas they're having a seizure and it doesn't abort in a couple of minutes, it going on, seizure can go on for hours sometimes. You want to give medication. So yes, we've tried to give a drug that it may be difficult to get a line when they're convulsing. So you may put diazepam, rectal, put in their anus, they have suppositories you put in, or in their mouth, they have something called buccal midazolam. So they're drugs you can give in their mouth, in the cheek. So you just put it in their mouth and it melts and it gets
Mm.
absorbed in the blood and it stops this, control the seizure. Now, in terms of the management, we are talking about epileptic medication. So there are lots of drugs for epilepsy. And as I said to you, depending on the type of epilepsy, there are different drugs that we'll use. Now, sometimes we aim to use one drug. However, if one drug cannot work, we can switch to another one that works, or we give a combination drug. So some patients are on two types of anti-epileptic drugs. And these drugs, of course, got to be monitored. When you're using epileptic drug, just a little bit of scenario in terms of contraception pill. So, of course, first of all, you need to know that lots of the drugs that are used in epilepsy, you have to have, they can increase the risk of malformation in babies and they're not safe in pregnancy. So there are some that are safer in pregnancy than others. and we would tend to swap them. However, it is important to discuss with your doctor the type of drug you're taking if you intend to get pregnant. And then if you say, I don't intend to get pregnant, I want to take contraceptive pill, these drugs also induce your enzymes, and they can cause the contraceptive pill to be less effective. So certain pills you cannot take, like progesterone only pill you cannot take. If you're going to take the oral contraceptive, you may have to double the dose or something like that. Or we encourage more things like the coil or some of those form of contraception. So those are important factors for patients to bear in mind. That is, drugs used when they are pregnant, and drugs when they are having contraceptive pill or try to prevent pregnancy. There's another, in terms of the management, we have something called, you have intervention now you can do. So if you're not managed, there's something I forgot to mention. There's a type of diet patients can go on called ketogenic diet.
Oh, right.
Where you eat less carbohydrates, more fats, ketones, and more protein. So ketogenic diet. They say that it's helpful for patients who have resistant to medication. Their epilepsy is resistant to medication. They go on a ketogenic diet. There's a surgical intervention where you could put we stimulate one of the nerve in the neck, vagus nerve. There's a nerve called the vagus nerve, and you could do a stimulation of the nerve, vagal nerve stimulation, which can help to control epilepsy. So that's your management in summary.
Good. We got about 5 minutes more to go. So let me ask you this quick before I get into these two quick questions from last week. You spoke about children having this, having the, what we call the fever. During a fever, you will get seizures and so on. Is that does that in any way related to epilepsy though?
That is not epilepsy. That is febrile convulsion. There is most of those patients don't go on to have epilepsy. I think there's about 2 or 3% can have epilepsy, so they can be an association where they can 2 or 3% can have epilepsy, but 97% by and large, majority of patients, it's a short-lived epilepsy seizure, so that is not defined as epilepsy. So that, as I say, nobody knows exactly. It's a multifactorial cause. So you have genetic and you have environmental factors. What they say is that your background risk of febrile convulsion is 1 in 30. So 1 in 30 is about what? 3%? Yeah, so it's about 3%. If you have a sibling with epilepsy, your background risk increase to 1 in 5. So let's say about 20%. If you have parents and a sibling, another child, plus the parents, a sibling and a parent, both parents, you have a 1 in 3. So like 30% plus. So it runs in family, that febrile convulsion.
Thank you.
And of course, management is usually it would associated with fever, so upper respiratory tract infection. You tend to get it in the first 24 hours of the fever. If it lasts more than 3 days after fever, we would still investigate for other causes. Upper respiratory tract infection and certain types of infection, herpes infection they're attributed to febrile convulsions. They say there's an inflammatory process. Sorry,
listen. We're going with time, and I got just about 3 minutes more to go. Less than 3 minutes. You got 2 minutes to answer these questions. All right, Doc.
All right, go for it.
A friend of mine said that the doc gave her Daflon for her piles. Does that help?
Yes, it is known as a medication, but I don't know in the some countries it's not licensed. I'm not sure if in America it's FDA approved, but Daflon is a type of flavonoids that has got antioxidant properties and anti-inflammatory properties, they say, and it helps blood vessel. So it is not so well established as a treatment in all cases, but it is used in some countries. They use it for piles and veins and swelling of the veins and things like that. But yeah, that's okay.
Last one, Doc, I heard that hemorrhoids that the hemorrhoids that are protruding can fall off if you tie a string. Is that tie a string on it? Is that possible?
Well, we spoke about that.
Yeah, that's right.
Banding.
Yeah, that's right. Yes.
So that banding is like tying a string.
That's right.
But I don't know how you'll get to tie a string.
I know, but like then people have their own method by. Anyway,
Yeah,
Doc,
but
look,
that banding. So the string
yeah,
theory is the theory of how we band it. You put it, you know, you catch it and you slide a rubber band over it. There's
right.
a special tool to do that.
Well, thanks
All
so
right,
much for
I
that.
think.
Look, viewers, we're always strapped with time on the show, and if I allow Doc, he would take forever to discuss everything. But again, next week we'll be here, so join us next week for another program. Doc, anything you want to say in closing, please?
No, thank you, and I'm sorry, I'm rushed. Epilepsy is too big a topic, but I have touched on the basics, and
Yeah.
again, thank you and your team, and to the viewers for tuning in.
All right, good. Well, viewers, thank you so much. We come to you, as I said, we come to you live from TBN Studios every Tuesday night at 8, and you can always catch us back at any time. You can also catch it on my page and on Dr. SAWH's page. Also, go follow him on